My name is Ayo and I'm back again with another video. So today we're going to be going over first, next, best, most questions. Also, we're going to be talking about how to approach the ASWB exam questions. So like I said on my other videos, we're just going to get right into it. But before we start, I know people have said I talk really fast. So here's a reminder to make sure you slow down the speed so it can go at the speed that feels comfortable for you. YouTube has the option where you can reduce the speed, so I highly recommend if my speed is too fast, just change the speed. Okay, this is a gentle reminder to everyone. So let's just get right into it. So, when you're answering these questions, you want to make sure you are answering or trying to figure out what they're actually asking you, right? You want to identify what the question is actually asking you. So you're looking for keywords like first, best, next, most. Also, you're trying to figure out what's the focus. So I highlighted the safety, validation, acknowledge, and assessment part because these three are very important because after you do these three, then it really may change on what's the next thing to do. So safety is law, right? Safety is always going to come first. So when you're looking at these questions, you want to see, okay, what's happening here? What are they asking me? They're asking me what's the first thing, or what's the best intervention, or what's my next move? And that's going to make it easier to answer these questions. Also, something else you want to consider is the scenario. Being in a prison versus being in a private practice is going to be a bit different. Being in a prison, a person may be mandated to be there versus a person going to private practice. They are. I'm not saying you can't be mandated to go see a clinician outside of prison, but just looking at the different scenarios can help you figure out like, okay, how do I answer this question? So first one, so you want to identify what the question is asking you. Next, you want to follow decision making framework, right? So safety's first, like I said before. Safety is first. If the question involves suicide ideation, self harm, abuse, violence, medical risk, your first step is to ensure safety. So you want to look for answers related to suicide assessment or safety planning, mandated reporting, emergency intervention, or hospitalization, right? So that's what if you know safety comes next, right? If you have a patient who is suicidal and they are telling you you're not going to see me next session, yeah, safety's first is going to be something like that. Or if you have a client who, let's say they say has BPD and is engaging in self-harm activity, and then also engaging in impulsive behavior, something like that. Safety is the first thing you got to do. Okay, so that's the first. So next, the building rapport, validate and acknowledge. So if there's no immediate crisis, you want to validate the client's emotions and experience before jumping into solutions. I know sometimes when people are actually practicing, they may try to offer some type of solution or something like that. But here we don't do that. You really want to make sure that you are focusing after safety. You're building rapport. So you are validating and acknowledge the client's experience. So you may acknowledge feelings, provide emotional support, building rapport. Those are the kind of answers you want to look for, like validating the client, stuff like that. So next with assessment. So in assessment stage, what are we doing? Gathering more information. So before making any referrals or interventions, you assess the situation thoroughly. So you look for answers like exploring symptoms further, clarify the issue, understand context. Exploring the symptoms could look like assess the frequency and severity of depressive symptoms, clarifying the issue, gather a detailed social and medical history, understand context, asking about substance use patterns before recommending treatment, that kind of stuff. And then we have intervention. So intervention, problem solving, skill building. So after assessing, choose the most appropriate intervention based on the client's needs. So you're looking for answers that talk about providing coping strategies, so teaching distress tolerance or psychoeducation, educating the client on trauma and its effects, cognitive or behavior techniques, challenging negative thought patterns, things like that. So intervention is the problem solving, stuff like that. Then lastly, we have coordination and referral. So if an issue requires additional resources, coordinate care and refer when necessary. So you're looking for answers that talk about like referring to a psychiatrist or an MD, or like let's say a client has a headache. like a really bad headache and they haven't seen a doctor yet, right? You may refer them to go see a doctor because it may not be a psychological thing, it may be a physiological thing, and they may need to go get other things checked out, right? Headaches can be nothing, right? Some people, based on their genetic and DNA and their biology, they just get headaches, but it could be tied to a lot of things. It could be tied to our diets. It could be we can get headaches because we're not sleeping enough. We can get headaches because we have high blood pressure. So it's really important for people to go talk to an MD because it may, like psychological counseling, may not be helpful, right? They may need medication or diet change or something like that. So this part is really important. So what I said before, so referring to psychiatry for medication evaluation, coordinating with medical teams, and connecting client to community resources. So yes, so now we are going to get into the questions. Okay, so I got 6. I'm going to try to talk a little bit slower here. Also, move the questions slower here so people can screenshot them and answer them before I answer them together. So the first question we have is: a social worker is working with a client who expresses distrust of authority figures and hesitant to engage in therapy. So this person is hesitant to engage in therapy. What is the most effective way to build rapport? So this question is actually, what is the most effective way to build rapport? So we want to know what we're building rapport, right? So we're looking for an intervention. What would be the most effective? So is it explain confidentiality policies and the role of therapy, share personal experiences to create a connection, acknowledge the client's concern and validate their feelings, ask the client to identify their therapy goals. So remember, we are looking for the most effective way to build rapport. So I went over what it looks like, what kind of answers, what kind of answers pop up when they're asking for that. So is it A, B, C, or D? Okay, so I hope we all pick C here. Okay. So the answer is C. Why is the answer C? It is asking you, building rapport. What is the most effective way? I went over earlier. Where is it at? Validate, acknowledge, build rapport. There's no crisis. When acknowledge client's feelings, provide emotional support, build trust. So here, answer, acknowledge the client's concerns, validate their feelings. That is the correct answer. I hope that makes sense. Next one. A social worker A social worker is working with a client diagnosed with borderline personality disorder, BPD, who frequently engages in self-harm. What's the best approach to address this behavior? So this one may be a little bit tricky. If you don't know much about DBT, you may not know how to answer this. So it's asking you what is the best approach to address this. So something everyone should know, right? With BPD, right? What is the gold standard treatment for people that have BPD? Is DBT. DBT for BPD. DBT can help a whole bunch of other people, right? It's not just BPD. It was created for people that have BPD, but it has been shown to help people with depression and PTSD and ADHD and a whole bunch of other people. But BPD was created for people with BPD. In DBT, we have skills, right, that we teach people. So because of that, right, these skills are there to help people not engage in these maladaptive behaviors. So it's asking the question, what's the best approach to address this behavior? So this one's a little bit tricky. So I just gave you some background on DBT, but let's go into this answer. So the person is engaging in self-harm. So is it implement safety control requiring the client to stop self-harming? Is it to encourage the client to address emotions verbally instead of through self-harm? Is it to teach distress tolerance skills to help the client manage emotional triggers? Or is it to refer the client to inpatient psychiatric facility for crisis stabilization? So this one is hard because, right, I think most people may pick A, which is implement a safety contract, or may because of safety. But with BPD, right, we teach people distress tolerance skills so that way they don't engage in those maladaptive behaviors. So things like the tip skill and things like, what's another one? Tip. We got self-soothe. We got improve the moment. We teach all these skills to help people to not engage, right? When they want to engage in behavior, they use skills to kind of help change the behavior, and they no longer engage in maladaptive behaviors. So the answer here is actually C, right? A little bit tricky, but I've seen on some practice questions stuff on BPD and DBT. So if you're not familiar with that, definitely look into it. If you want me to make a video, I actually do DBT therapy. That's one of my main modalities, DBT and EMDR. But if you are a person that you're not really familiar, I can go over that stuff. If you want another video, but not if people don't want that, they don't have to. But I would say just look into DBT, understand what DBT is about, who was created for, who it can help, how DBT is done, that kind of thing. Because I actually have seen quite a few practice questions on with BPD and DBT. So definitely something to look at. So the answer here is C. Okay, so next. A social worker is facilitating a group for survivors of domestic violence. One participant shares a traumatic experience and starts crying uncontrollably. What should the social worker do next? So think about if you're running a group, person is crying. It's a group for people who are domestic violence survivors, right? What do we do? So is the next thing we do we ask the patient to step outside to calm down? Do we offer validation and encourage grounding exercises? Do you redirect the conversation to another participant? Or do we end the session early and allow the participant time to recover? So here, remember, it's actually what's the next thing to do. Someone is crying uncontrollably. They're having a hard time. What do we do? So the answer here is going to be B. It's going to be B because the person is crying. They need a bit of assistance. It would definitely not be appropriate to tell someone to leave because they're crying. I don't know how other people do therapy, but it's okay to cry. And I think it would do more harm if that was the way we would do things. So I definitely wouldn't recommend anyone telling a patient to leave a room because they're crying, especially in a domestic violence group. But the answer here is B. So, asking the person to step outside is not correct. Redirect the conversation. That can be invalidating or dismissive. Or end the session early to allow the person to time. That wouldn't be appropriate. If you're running group, right? Group, when you think about group, the group is the patient. So you want to maintain the cohesion. And in times like that, right, you can offer validation and you can model behavior. And then that could prompt the other participants to model that behavior and offer that client validation, which is really good, right? So the answer is B. So next, a hospital social worker is assessing a patient with a history of opioid addiction who's requesting pain management after surgery. What is the most appropriate intervention? So most appropriate. So it's actually with the most appropriate intervention based on the circumstances. Person has a history of opioid abuse, right? This is a hospital setting, right? So think about what's most appropriate. So does it inform the medical team of the patient's addiction? So it's actually for an intervention, okay? Educate the patient on non-opioid pain management options, okay? Encourage the patient to seek addiction treatment after discharge, okay? Develop a pain management plan and collaborate with the medical team. So think about it. It's asking you for an intervention, right? And you're in a hospital setting. Okay? You're in a hospital setting. What are we going to do? So the answer here would be D. Okay? So develop pain management, develop a pain management plan in collaboration with the medical team. This is a hospital setting. If you ever worked in a hospital, you know how it is. You're not just going to educate the client. In the hospital, right, interdisciplinary teams, you're going to come together, you're going to talk about it, and come up with the pain management plan with the team. That's how hospitals run. Maybe it may look a bit different if this was like a private practice setting, but because it's in a hospital, the most appropriate intervention here would be D. Coming together with the medical team and coming up with a pain management plan together for this patient. So, next question. A client with major depressive disorder expresses suicidal ideation and denies having a plan or intent to act. So, they deny having a plan or intent. What should the social worker do next, right? So, is it develop a safety plan with the client, hospitalize the client for further evaluation, explore the client's reasons for living, or refer the client to a psychiatrist for medication management? So remember we talked about this earlier. So now the client says, I'm not going to do anything. I have no plan. I have no intent. I just feel suicidal. I just want to escape. I don't want to be here anymore. What do we do next? So safety. The answer is going to be A. Develop a safety plan with this client. So if you have never worked with high-risk clients, you may not know what to do, right? A person saying, hey, I have suicidal ideation does not mean that they're going to do anything. The number one risk of a person attempting suicide is if they tried before. Okay, that's the number one risk. Like if you have a client, even if it's been years and they tried to do it before, right? That's the number one indicator that hey, they had the strength to do that again. Okay, but there are some people who they have had suicidal ideation for all their lives, right? It's just a maladaptive coping mechanism. It's something that makes them kind of calms them down because it gives them an escape. That for some people that's how suicidal ideation is. So putting them in a hospital may not be the best thing here. Okay, because for some people, putting them in a hospital, they're more likely to try to do it. Because now they're like, yep, you put me here. That's it. This was terrible. The hospitalization, it's not going to get them better. A lot of times with hospitalization is there to make sure they don't do anything and to kind of just bring the situation down. But for some people, because of what they experience in the hospitals, they try to do it. In DBT, they talk about that a lot. Like, hospitalization may not be the next route if you have a client who wants to do it. A lot of times it's about building that rapport and having that trust and having clients have safety plans and have skills and have things that they can do to help them have support systems and things like that. So the answer here is A. Okay. And last question. A social worker is meeting with the new client who reports experiencing auditory hallucinations. What should the social worker do first? So this person is having auditory hallucinations. So should we assess the content and impact of the hallucinations? Should we refer the client to a psychiatrist for medication? Should we teach the client coping strategies? Or should we explore the past trauma that may be contributing to the symptoms? So remember what we talked about before. What do we do first? So safety seems okay. They don't give us an option to validate or acknowledge this client's feeling. So what do we do next? Okay, we assess the content and impact of the hallucinations, right? It's asking what do we do first. And with those first questions, you definitely need to think about safety, validation and acknowledgement, assessment. That's the order with these first questions, okay? So that's all I have for today. I hope this was helpful. If you have any questions or don't understand why something is right or wrong, please leave a comment and I'll try my best to explain. But I hope this was helpful. Again, please, when you are looking at these questions, especially these first questions, think about safety, acknowledge and validate, and assessment. If you can remember that, it's going to be a lot easier to answer these questions. Also, make sure you are reading the question. If it's asking for the best intervention, that means you have to do something, right? An intervention means we're doing something. So, just make sure you are reading the questions, looking for the best, next, most words, also looking at the setting that the question is in. And I honestly believe if you can do it, you can pass. So I wish everyone all the best of luck. I hope this was helpful. And If you have any suggestions of my next video, leave a comment and I'll see you all next time. Thank you. Have a good night. Bye-bye.